Welcome back to the Lift Free and Diet Hard podcast. I'm your host, Andrew Coates. Join me along with industry leaders and friends on a quest to get more people through the gym door and eating and living healthier. Join me where evidence meets empathy while rejecting fitness industry fads and extremism. Let's begin. Dr. Susie Spirlock, it's awesome to have you back, my friend. And for those of you listening who are not overly familiar with Susie, well, like any guest, I want you guys to go follow Susie, but you are a doctor of physical therapy, and you're also a prolific educator, and you've been working with Barbell Rehab, Dr. Michael Mash, who I'm going to make the effort to get on pretty soon, too. I've just had a lot of really smart physical therapists, strength coaches who deal in injuries and rehab. So thank you for coming on.
Absolutely. Thanks for having me back. I feel like this is our third time doing podcast stuff together, even though it's been on like different podcasts. So I'm super excited.
You're right. You were once on this one, and then
Yep.
the other podcast, which now defunct, that I was doing with our friend Bailey Lau, who's my former business partner in my women's Forever Strength program. So yeah, that's right. I almost forgot about that.
It is.
Okay, so let's dive right in. I've got a whole bunch of training concepts that I think you can do a great job with. So let's go right into this one. Why doesn't stretching alleviate tight muscles?
Ooh, so there is a time and the place for static stretching. So when we're talking, usually when people are talking about stretching, they're talking about, the ones where you sit on the floor with your legs out and you're just like stretching from one way to another. It does have its time and its place. Think about, the progress that gymnasts make with this stuff. Think about the time and progress that, contortionists and whatnot spend in these positions. However, the amount of time that you have to spend in these static positions is a long time. And unless you're following it up with something like load, or unless you're like putting more of the focus on load itself, it's going to take you a lot longer to sort of increase any muscle extensibility in the first place. And loading is actually going to be what's better for the long-term benefits of not really feeling that sensation of that muscle being tight. It's a common misconception that when a muscle feels tight, that it needs stretched. Obviously, that's what we've been taught, right? Well, that muscle tightness is actually more so due to your nervous system changing that resting tone of the muscle. And so instead of just kind of stretching it and holding in this position, especially for people when it comes to hypermobility, instead of just stretching, we see some massive benefits both with strength and muscle extensibility of, let's just say if I'm referring to my upper trap, instead of stretching it, I'm going to take it through ear to shoulder and contract the muscle and then elongate and kind of do it in more of a dynamic nature since it just talks to the nervous system more.
And I've certainly noticed, and I think there's good evidence to support this, that like static stretching doesn't seem to be a particularly great way to warm up for exercise. I actually don't think it's as bad as some people make it out to be,
Right.
but dynamic stretching seems to. Can you explain even further what good examples of dynamic stretching are and the difference?
Right. So a static stretch, let's just talk about your hamstrings, for example. Let's say you're going into the gym, you're going to do a lower body hinge day, and you want to warm up your hamstrings. So a static stretch for a hamstring can look like just standing up on your 2 feet and hinging your hips back and keeping your knees straight and bending and reaching towards the floor to try and feel that stretch on those hamstrings. A dynamic stretch can be something more of like, I like to call them elephant walks, where you have, you're standing on your feet and you have one hand under each foot, like your fingertips, and then you're just kind of bending and straightening your knees back and forth. So the main difference between those two is static, you're holding a still position, versus dynamic, where you're kind of moving more in and out of that position versus just being still. And like you mentioned, obviously there is a time and a place for static stretching. Before a workout, it used to be people used to say, oh my gosh, don't static stretch before a workout. It's going to hinder your gains when it comes to muscle contraction and muscle growth. But we know that as long as like the static stretching is kept at or below like 2 minutes-ish for a certain muscle group, that you're not really seeing any negative effects on performance. A lot of people will sort of either feel a little bit stiffer after some static stretching, or they will actually be stretching some nerves that are holding more tension versus the muscles, which can then sort of result in an extra sensation of tightness as your body is trying to use that as a protective mechanism.
Is this sort of like the body nervous system sort of guarding? You're doing something that's threatening, creating
Mhm.
an unpleasant sensation. I'm rephrasing. And then the nervous system saying, no, 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 we don't like that. So it doesn't guarantee that you'll actually relax the neural tone. Will it
Mhm.
often intensify the neural tone of that tightness?
It can, yes, especially if you are doing static stretching and you're putting yourself into such an uncomfortable position where you're like holding your breath and the rest of your body's tensing up. If you are doing static stretching, you need to be able to get into those positions and learn how to do some breath work and relax and talk to the nervous system that way so that your body knows, oh, this is a safe space and a safe range of motion to be in. I don't have to freak out from being here.
This episode is brought to you by Renaissance Periodization and the RP Hypertrophy app. RP is the industry leader in muscle building, coaching, and education. This app is like having a coach in your pocket. It gives you everything you need, including training programs, form videos. It gives you all your sets, reps, and weights, so you just show up and follow the plan. It adjusts each week based off your progress. And the app was created by Dr. Mike Isertel, Nick Shaw, and the team at RP, who I've known for many years. And the entire team are incredible people who've always been supportive and generous with me, so I know their character and are easy to endorse. My library contains several RP books, and I've used RP training principles in my workouts and coaching with my clients for many years, long before the explosion in popularity of their YouTube channel, which is worth checking out. RP is the first sponsor I felt remotely comfortable endorsing after over 7 years of podcasting. And if hiring a one-on-one coach isn't for you, using the RP Hypertrophy app is the next best thing to maximize your gains and take the guesswork out of your program. And there's a 30-day money-back guarantee, so you can try it risk-free. If you don't like it, they'll give you your money back. And I've also got a serious discount for you of up to $50 US. Go to rpstrength.com/coats and use the code COATSRP, or go to the link below in the show notes. And that's rpstrength.com/coats. Use the code COATSRP. What are your favorite ways to then warm someone up to maybe relax the neural tone of, let's say it's a tight muscle, tight joint where someone's having a little bit of restriction in the movement that they probably need for the exercise? What are some of your favorite modalities?
Oh, it kind of really depends on the client. That's
Mhm.
like the typical PT answer. But generally speaking, when it comes to how I like to structure warm-ups, is I usually include some active mobility or dynamic stretching drills. So if we're thinking of like an upper body day, I might have someone do some close-packed shoulder capsular rotations where you have your forearm on the ground, your body weight over top, and you're kind of rotating your arm back and forth because your body weight is on top of that shoulder capsule.
Mm.
And then I'll usually go into some active awareness drills for muscles. So that could look like something like a banded face pull with shoulder external rotation to really just kind of get everything moving and get the blood flowing. And then sometimes I'll do a second muscle awareness drill. And then other times I'll go straight into a plyometric so that we can not only learn how to be more aware of the muscles, but now start to move a little quicker. And then after that plyometric is where I'm having clients go into the main compound lift of the day, doing anywhere from like 2 to 6 warm-up sets of that main compound, depending on the load, and then getting right into the session. I feel like warm-ups have kind of become a little bit longer than they should in mainstream, just because everyone is so worried about all the fancy mobility work that they see online, which is not inherently bad by any standard of the means. But the meat and potatoes of the things that are going to happen in regards to increasing range of motion, strength, bone density, hypertrophy, which is muscle mass gain, all of that stuff actually occurs in the training session and not in the warm-up.
I'm a huge, huge fan of light sets of the planned exercise, right? You said that.
Yes.
And personally, like I think we know that foam rolling doesn't have any lasting effects on adaptation. Like you're not breaking up adhesions or scar tissue. That's nonsense. But I find that a little bit, even though it's not necessarily well supported by quote research, a little bit of foam rolling, not too much, and not too much pressure where it's painful, seems to loosen people up. And I find that it seems to feel pretty good. And anecdotally, and I've seen people like Mike Robertson is sort of a classic strength coach who's always advocated for this as part of his warm-up programs. And I've just noticed that for this certain client, for the right kind of stiffness and soreness, some often feels better. It's just something I found that works really well. So
Yeah. And I used to be someone who loved foam rolling. Like foam rolling was like the golden nugget of warming up and feeling good. And then, when I got more experience, dove into the literature, and then I was on the other camp of like foam rolling is useless, like we don't need it for anything. And now as I have matured, I'm kind of actually somewhere in the middle. So although it's not like breaking up scar tissue, it's not making your muscles longer, it's not breaking up adhesions. it is still talking to the nervous system because you're putting pressure on a muscle, and those muscle receptors are like, oh, shoot, we have some pressure changes going on within the muscle. And then that sends a message to the brain, and then the brain's like, oh, let's send another message to kind of chill the muscle out. And it sends another message back down the spinal cord through the nerves and says, hey, muscle, let's chill out a little bit after getting that nice, like, hurts so good input from the foam roller itself.
Now, you mentioned hypermobility earlier. So,
Mhm.
within the context of what we already just talked about, what's going on with most people with hypermobility, joint laxity, and you, we also were talking off air about Ehlers-Danlos syndrome, and that seems to be more common. I used to believe it was rare. I have an old friend who had it, and she would tell me there wasn't much information about this 12, 14 years ago, but now I'm noticing that the incidences of this are much more common. So, can you explain what's going on there?
Yeah, absolutely. So hypermobility occurs on a spectrum, meaning that someone could have every single joint in their body that is hypermobile, where your ligaments are a little bit lax, so they aren't able to really hold the joints together as best as in someone who doesn't have any hypermobility. And that's what allows you to do all your fun little party tricks and basically look like Gumby. And then we have a type of hypermobility. Well, actually, you can have Ehlers-Danlos syndrome. Basically, that is a inherited genetic disorder. I say that in quotes just because I don't like using the word disorder,
Mhm.
of where you can have joint laxity, not only hypermobility wise, but also within all of the other connective tissues in your body. So think connective tissues of your veins, of your gut, of your heart, everything is affected. And so you can have hypermobility and Ehlers-Danlos syndrome, or you can have just hypermobility and just have the connective tissues of those joints affected, or you can have a type of Ehlers-Danlos syndrome that doesn't really have a ton of those joint hypermobility aspects and more of the sort of internal connective tissue organ stuff. So there's like a wide range and a wide spectrum. And one of the reasons why I think it is becoming more popular now is because a lot of people who are around my age in their 30s have just now been diagnosed within the last like 5 years and or are continuing to be diagnosed as they get older. So it's a large incidence, especially women who are realizing a lot of the connections between a lot of their symptoms and then sort of trying to chase a diagnosis to make it make sense.
So, is it like I know that there's sort of a spectrum, so I'll try to explain. There are definitely clusters of symptoms that don't necessarily have a clear cause. I'll use maybe leaky gut is one of the ones that's a little bit more dubious. Probably fibromyalgia is one of the ones I think there's a bit of argument about, and then they seem to be catch-alls when everything else is irritable bowel syndrome. Sorry, that's the big one, not leaky gut, irritable
Yeah.
bowel, where okay, we just know that these are the symptoms, and everything else is ruled out, and we kind of go, okay, well, this is kind of what it is, and it's more of a description of symptoms, but that's not what's going on here with Ehlers-Danlos. That's a very distinct, like diagnosable thing, correct?
Correct. Yeah. And
But
even
people
though
weren't,
sorry,
go
go
ahead.
ahead.
I was going to say, but people weren't necessarily connecting the dots on the symptoms because there wasn't as much awareness now that we do. Then people are understanding, wait a minute, I have all these things, and it's actually like a clear-cut case. Definitely, it's not the same thing as an IBS. Okay, gotcha.
Yes. But even though it's not the same thing as an IBS, a lot of people with hypermobility, especially Ehlers-Danlos, will have your typical IBS or quote unquote leaky gut, a lot
Oh,
of dysautonomia, which is basically sort of a misfiring of your nervous system. And it can lead to things like brain fog and chronic fatigue and POTS, which is postural orthostatic tachycardic syndrome, meaning that when you change position from like sitting to standing or the floor to standing, your heart rate spikes really, really high and it makes you super, super dizzy. We also see correlations with EDS and hypermobility and people being neurodivergent and having more like ADHD and anxiety and depression stuff. So there is a lot of crossover and a lot of these symptoms kind of occurring together, which actually sort of can help physicians and specialists put the puzzle piece together and be like, oh, this is why you're experiencing all of these different systems that are affecting all of these different body systems because of your connective tissue, not because you are just someone who is trying to make all this stuff up in your head.
do we see any increase in some of these symptoms in perimenopausal women? I pose this because one of my best friends right now, who's in this, and she's been asking me questions, is she's basically dislocated both of her kneecaps, and she's noticing some stuff with along these lines. Is there something there? Because in my limited understanding of this, I do understand that there can be some loosening of joint tissue due to hormonal stuff during menopause. Am I correct?
Yeah, so I haven't dove super, super deep into the literature when it comes to this. I honestly, it's still sort of new, all the stuff
Hmm.
that's coming out about hypermobility and EDS, but there definitely are significant hormonal changes that take place, especially with estrogen, as someone goes through perimenopause and menopause, that can affect multiple different body systems. So I can't see why it
Hmm.
wouldn't affect sort of the connective tissues and also the gut. And basically, our body is run by hormones in the first place. And so the big dips and the big drops and the big changes can definitely have an effect on all this stuff.
So, what would you say tactically for someone who is for whatever the reasons they deal with joint laxity, hypermobility, to help them avoid injury and get stronger?
You got to strength train under some load. And that is a really, really hard concept for a lot of hypermobile people to sort of grasp because they think, oh, well, my whole entire body feels tight. I need to stretch. And then they stretch and then they get relief for, I don't know, 10, 15, 20, 30 minutes. And then that tightness immediately comes back and they feel a need to stretch again. These are your same people that say, oh, my hamstrings feel really tight. But then when they go to do a hamstring stretch, they quite literally bend over and palm the floor with straight knees. And I'm like, no, 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 you don't need more stretching. You need to build up your tissue tolerance and your muscle strength because when it comes to everything that we have going on with a joint to kind of hold it all together, we have the ligaments, which are the connective tissue that's affected most in EDS and hypermobility. And then we have our muscles, which turn into tendons, which connect to the bone to move the bone. And then we have the joint capsules themselves. So we can't really make any changes to the joint capsule. We can't really make any changes to the ligaments. So the last sort of thing that we can actually have a say in how strong this stuff is our muscles and our tendons. And so there are so many clients that have come to work with me and my team virtually, and we've taken them out of the stretching realm and into the strengthening realm. And a lot of these symptoms of the chronic joint pain, the achiness, the tightness feeling, the nervous system just being in overdrive all the time have slowly decreased as they have gone through some nice structured programming, some nice floating made to work with their body versus against it.
Is an element of this actually training the motor skill of getting into these positions too?
Yes, because we all have these little sensors within our joints. They're called proprioceptors. And those proprioceptors basically tell us where our body is at in space. So if I'm talking to you and I have my arm like extended out behind me, I know my arm is behind me without even looking because of those proprioceptors. When we have joint laxity, those proprioceptors don't have as much input into the system, which can then result in us usually wrecking into doors or into the side of countertops or just really just have bad body awareness. So not only are we working on strengthening, but we're also working on the motor control aspect of things, doing things slow, doing things intentional, and really, really working on that so that someone can not only get stronger, build some muscle mass, but also increase their coordination, proprioception, body awareness.
What do you say to the person who I genuinely believe that people gravitate to things they're good at. So the type of people who probably like doing yoga are people who are already pretty flexible, right? As opposed to guys like me who are super stiff, right? We go in there like, this feels terrible. I'm not good at this. I don't want to be here with a group of women who are just like making me look really bad. But so what do you say to the person who probably gravitates to the more stretching, maybe the yoga type stuff, or puts themselves in these Gumby, bendy, performative ranges of motion when in fact that actually might be bad for them?
It's always a tough conversation to have because, like you said, I mean, these people are flexible, they are bendy, they like the things that they can be successful at, which is being flexible and bendy. I have time and time again, clients come to us and they're like, yeah, I do a ton of yoga each week. I do a ton of static stretching. And then when you ask about, hey, what about strengthening? What about, some muscle endurance and body awareness? They're like, oh, no, I don't do any of that because it's so hard. It's so hard for me to do that stuff because it's really hard to make those neuromuscular connections and they just don't have the brute strength for it. And so we aren't saying, oh, we'll stop doing all of that stuff entirely because a lot of times these are modalities and forms of exercise that people actually really enjoy. So instead, we just do a ton of education. I mean, like, hey, I know you love yoga, But instead of doing the types of yoga where you are holding super deep stretch positions for 3, 4, 5 minutes at length and working on breathing in those positions, instead, let's work on some more of the flow-based yoga where you have to hold that muscular tension and have more dynamic movement through the session or the class versus being in those super stretch positions. And then I also like to recommend Pilates to some of these people because Pilates can be not technically strength training, but obviously not yoga either. It's kind of somewhere in between where we are working on more coordination, muscular endurance, and holding positions while also working in the mid ranges of different movements. And so that can be another form of exercise that they can do along with some strength training in their routine to make sure things are variable and make sure that they're still doing stuff that they enjoy.
And I'll say something in defense. I'm very positive about yoga and Pilates in context. In their
Yeah.
defense, there are going to be a lot of positions like as again, I've never done Pilates, but I've done a little
It's
bit of
hard.
yoga, right? And if it's hard and you're holding body weight positions, or in Pilates, I guess these positions against resistance, and it's hard to the point where it's to near failure, even under your own body weight. Well, guess what? That's progressive training. That's how's that any different than calisthenics to near failure under your own body? Like, if you're not able to get near failure, you're probably not going to do much for strengthening. But if these things are new to you and they are hard, and
Mhm.
again, near failure, you will build muscle and get progressively stronger, right? So it's enough stimulus to change.
It is. And do we want to open up that can of worms? Because I will go there with Pilates and strength training. I mean, I feel like we're already here. So
Sure.
I feel like there's a war right now on social media of Pilates not being strength training, and then people in Pilates taking that personally, and then strength training gym girlies saying that Pilates is useless and there's no really need for it. And the answer is it depends, and it's usually somewhere in the middle. So just like you said, if you were doing Pilates, you love that form of exercise, you are newer at it, and you are able to get sort of closer to failure within that 30 rep range, then you are definitely using enough muscles and to achieve that muscle adaptation of the muscle growth and the strength aspect. However, if you're having to go over the 30 reps for a lot of this stuff, per the literature, we know that that is more working on like the muscular endurance aspect of things. And as you get better and stronger at Pilates, you're going to eventually need to put on some load, whether it is weights, whether it is wrist straps, and that is where sort of mat Pilates normally hits a wall. But then you add in the reformer aspect of everything, where you can actually really use that as some progressive overload, which we love. However, when it comes to pure sort of strength training and achieving that muscular failure a lot sooner so that we can have more of a central nervous system stimulation, we're not seeing that happen within Pilates. So in a perfect world, you kind of want both forms of the exercise. They are both great forms of exercise and they both bring a lot to the table. They're just different.
I love that. I love the nuance of it. And it's always nuance. Clickbait,
Right.
social media doesn't ever do it justice.
No.
Now, natural progression of what we're talking about, hypermobility and joint laxity. What is tendinopathy? And I think we had a lot of different misconceptions about it. Tendonitis was the old term, I think. Can you explain what's going on there, why the terms have changed, myths, and what is actually happening on a tissue level?
Yeah. So, like you said, it used to be called tendonitis. Um, Tendon meaning the tendons being affected, and the itis meaning inflammation. So, it used to be thought that tendonitis or tendinopathy, the main driver was that inflammation, meaning that the inflammatory response is what's causing most of the pain and the quote unquote dysfunction in the tendon itself. Well, thank you, science, when we were able to get better ways to look at what's actually happening, we know that tendinopathy is occurring because of thickening up of a portion of the tendon and or the fibers of the tendon, those collagen fibers, becoming a little bit disorganized. So the fibers of a tendon should be sort of nice and parallel to one another, but when we have an overuse injury happen or when that tendon is used too much, too fast, too soon, and things start to get a little bit wonky, those collagen fibers kind of get a little bit disorganized and are no longer nice and parallel, but a little bit janky. When we look at the literature, they've basically kind of grouped tendinopathy into two different camps. So group one is called reactive tendinopathy, and that's basically your acute tendinitis that we used to refer to, where let's say you were doing, you wanted to get back into strength training and you decide to load up super heavy front squats after not front squatting for 6 months, and you trained with the same load as you did previously. Well, your tendons could come a little bit cranky because they've just been loaded up too much, too fast, too soon for what you can currently handle. Most of the time, when it comes to reactive tendinopathy, just changing some volume, whether it's in your lifting or your running or your yoga, can be really helpful to kind of calm this stuff down. And then on the other side, we have degenerative tendinopathy, where we have been sort of pushing our tendons to their brink for quite some time without either one, knowingly that we're doing this, or two, just something where we didn't really have a pain response associated with it and we just kind of kept pushing. And now this is where that disorganization of the tissue happens. The unfortunate part of this is that this type of tendinopathy isn't really reversible, unlike reactive, where if we take down volume a little bit, incorporate some smart loading, things can actually heal within the tendon. But with degenerative, things are just going to kind of stay that way. The good news is that there is still a lot of the viable part of the tendon that surrounds the rest of that disorganized area that we have to work with. So I know some of the literature, I forget the name of the study, but he basically said treat the donut, not the whole, meaning that we want to focus on the viable portion of the tendon as the donut and not really worry about the disorganization of the tendon in the whole.
Having tendinopathy increase the risk of a tear, rupture.
Yeah, it can, because as you overuse these tendons too fast for what you can handle, that portion of the tendon that's affected, whether it's thickened with reactive tendinopathy or disorganized with degenerative, it becomes a little bit of a weak link and a little weak spot within the tendon. So if you keep kind of pushing it week after week, month after month, year after year, this is where we can run the risks of having some like avulsion tears away from the bone.
And I've seen in, not so long ago, one of the ways that people seem to be dealing with this stuff was like heavy eccentric overloading of these tendons.
Mhm.
Does that work, and are there any other viable strategies that will help improve either the quality of the tendon itself or diminish the discomfort?
Yeah, so when it comes to heavy eccentrics, that used to be the go-to, which in essence it still is. But when it came to heavy eccentrics, what was happening is people weren't actually doing the full, like, recommended 6 second lowering eccentric, because 6 seconds is a long freaking time to do an eccentric exercise. And then that also runs the risk of resulting in a lot of DOMS, or delayed onset muscle
Mm.
soreness, for the fact. And so researchers actually took that 6 second eccentric and they're like, well, what happens if we split it up over the course of a rep versus just on that lowering phase or that eccentric? So they pretty much took that and renamed it into heavy, slow resistance training, where we are still lifting heavy with about 70% of our muscles' ability to contract. We are lifting slow, meaning 3 seconds on the way down, 3 seconds on the way up, but that is also taking some of the load off of that heavy eccentric, minimizing that really, really hard muscle soreness. And also, people are just more inclined to do that type of a rep versus like a 6 second, really, really slow eccentric. So, in a nutshell, yes, but it's just named something different, and it's just a little bit different about sort of where we're focusing on when it comes to the portion of the exercise that you're doing.
This theme has come up in several recent episodes. Is another key part of it just managing the load, intensity, and volume that you're training with?
Yes, and that is major. Because as long as you have a good program and you're managing the load, managing the intensity, managing the volume, managing recovery, most of the time you're going to be able to sort of skirt by without really having much pain or injury. But it's when you're doing a programming that just has too much volume, too much load, or you think you can do more than what your body can handle after not really doing a ton of this type of loading, that's where we sort of run the risks of increasing that injury risk. So it's not necessarily the movements you're doing, it's just asking your body to do something that it's not really prepared to do yet.
And this kind of goes into the whole argument about, that form on exercise doesn't have as much of a isn't as much of a risk factor for injury as we once believed. And every young trainer coming up through, you automatically think every client coming in says to me, "Hey, I want to learn how to lift safely." Now, I'm not comfortable throwing this one out to say there's no relationship between form and injury risk. I don't feel good about that. But what I interpret it now as is form is usually breaking down because someone's probably using too much weight. So it's still a load management issue, and therefore
Mhm.
the form is deviated because so what is it? Is it a form issue or is it a load issue? And I think it's starting with the wrong load.
Yeah, and I would definitely agree with that. Same thing as foam rolling. I used to be in the camp that your form has to be absolutely perfect and your technique has to be pristine, or else we're not loading anything. And then as research came out, I went into the camp of like, oh my God, form doesn't matter at all. But now, since I'm smarter, I'm kind of somewhere in the middle when it comes to that. And it's more or less preparing your body to do a movement and explore different variations with form a little bit. But still, we kind of want there to be certain sort of checkpoints when with each main compound movement, like your squat, your bench, your deadlift, even to your lunge and your overhead press that we want to see. And then there can be variance within that. But, form still is something that does matter more from a mechanical efficiency aspect of a lift or a movement, more so than like an injury risk.
And, in my experience trading a lot of people, I cannot count the number of times that a client has expressed that a certain position or movement was uncomfortable. And I know that the load is fine. And then you provide that one cue, and oftentimes it's how torso is organized. So let's say low back discomfort in a like a Romanian deadlifting type motion or some sort of hinge posture. Maybe it's like a bent over row. And you get them to probably, I like to cue ribs down so that way they get their abs to engage a little bit. And despite all the fighting over neutral spine posture, whatever, I find that if you get a lot of people into a more neutral spine by getting them to engage their abs, then we find that low back discomfort in these positions tends to go away. Now, discomfort is not injury, but there's probably a spectrum relationship there. So I just don't want someone doing this stuff where they're uncomfortable. And if a simple cue about how to organize your body makes that go away, that's just net positive to me. So I've seen that, and load is not the problem. So again, I
Mhm.
think this stuff is nuanced. What about you also, this is a quote from you on a post. When it comes to soft tissue injuries, RICE, which is rest, ice, compression, elevation, the traditional belief, and NSAIDs, non-steroid anti-inflammatories, are outdated and ineffective. Why?
Yeah, so that post made a lot of people on the internet angry. It's like one of those posts that ended up on the wrong side of Instagram, where people took it personally. And I was sort of scratching my head about like, why are we taking this personally? This is a good thing. This means science is evolving and we are
Mm.
getting better at treating this stuff. But basically, like you said, RICE essentially stands for rest, ice, compression, elevation, and that has been the go-to for soft tissue injury management for like I feel like decades. And it was actually coined by a physician back I think it was the 70s, I believe, 60s, 70s maybe. And he has since redacted his own statement saying that, hey, this doesn't really align with what we know is actually happening and what's going to help these tissues. But yet, this is still being taught to nursing programs and physicians. Even some PT schools are still teaching it. And the reason why it's outdated is because we know that when you have a soft tissue injury, and soft tissue injury means that you have a sprain or a strain. So a sprain is like spraining your ankle where you roll your ankle, where we are having an overstretch of some of that connective tissue, like your ligaments. And then a muscle strain is when we're actually having a soft tissue injury to the muscle belly itself. And I guess you can kind of lump tendons in there a little bit because tendon and muscle are besties. That could be, you were playing soccer and you were cutting on a field and you felt your quad just kind of curl up inside of you. Well, you strained your muscle. And so for both of these different types, the last thing we want to do is rest it because resting immobilizes that area, which decreases the amount of blood flow to the area, which also decreases the muscle contractions. And we need blood flow to bring nutrients to the area to start the healing process. And then we need muscle contractions to help the lymphatic system flush all of those waste products of that healing process out, back, and up, down into the lymphatic system. And so when it comes to ice, obviously, if ice feels good for you, go ahead and use some of it. Like it's not really going to hurt anything, but it's also not really going to help anything outside of just some short-term pain relief management. We used to think that ice had the ability to help the healing process and constrict all the blood vessels, but when we were icing on the outside of our body, we're not really getting very deep with the tissues that that ice is actually affecting. I think it's like a couple millimeters, which if you have a deep quad strain, obviously the ice is not even making it down that far.
Mm.
And so instead of ice and cooling things down, we actually want to not necessarily heat things up and put a heating pad on it, just because that is not going to be comfortable. That actually might increase your pain levels a good bit. But bringing some more blood flow to the area through some movement versus trying to just totally stop all heat and stop all blood flow to the area. So instead of the RICE acronym, and instead of using NSAIDs, which are decreasing that inflammation, again, we need inflammation to happen. Inflammation is part of the healing process. And if we can let our bodies just kind of do what they're designed to do, you're going to have some better healing time in there. So instead of RICE, the new acronym that was popularized by Du Bois in the British Journal of Sports Medicine is actually peace and love. And yes, people say, well, that acronym's too long for clients to remember. And the answer is, yeah, it is. But guess what? You, as the healthcare professional, this is your job to educate. So do your job and educate on it so that they understand it. So peace and love stands for protection, elevation, avoid anti-inflammatories, compression, and education in the first part. So that piece is usually in the first like couple days of you having this injury. And protection doesn't necessarily mean rest. It just means, hey, avoid any like extraneous activities or movements that increase your pain above the 3 to 4 out of 10 threshold so that we can offload things a little bit, but we're not just like laying on the couch with a bag of frozen peas on our leg. Elevation's still good to do because again, that helps with the lymphatic system, pulling some of the waste products and the fluid and just some of that swelling back down to the heart where it can kind of be processed out. I already touched on anti-inflammatories and how we want to avoid those since they reduce the tissue healing. Compression, light compression, is still okay just because it can help sort of manage some of the swelling, but not to the fact where you're like wrapping an ACE bandage super, super tight around your ankle because again, that's going to limit the blood flow. And then we have the LOVE acronym, and this is like where a lot of the healing and just tissue adaptation takes place. So L stands for load. So letting pain just be your guide with a gradual return to normal activities, and then also increasing load to help build up that tissue tolerance is going to be the most beneficial. Optimism, which is huge because we know a lot of times when it comes to injuries, injuries can be frustrating. They can leave you feeling hopeless. They can leave you feeling sad. If you're playing sports, they can definitely take you out of your sport or the game. And so leading with optimism as a healthcare provider and saying, hey, like I know this sucks, but good news is we have a lot of strategies to implement in order to get you feeling better. V stands for vascularization. I touched on that, increasing that blood flow to repair the tissues. And then E stands for exercise, where we want to restore your mobility, your strength, your proprioception with an active sort of stepwise approach in order to get you back to what you want to be doing sooner.
Actually, I'm going to plug a resource that I have. It's free on my website. It's an article, and it's about cross education training with an injured limb. So you can absolutely continue to train the arm or leg if one is immobilized because you actually get a neurological benefit to the injured limb that helps reduce some of the loss of muscle thickness and muscle strength. And here's a big thing too. One of the problems with resting is it takes you out of your habit. It takes you away from an activity that promotes your mental health. And we know more than ever that being in the gym or finding whatever activity is really critical to a lot of people's well-being. And it also helps continue with the benefits, the metabolic health benefits of exercise, which is also a real thing. So we risk tossing that stuff all out if we go into an extended period of time of resting from an injury, even if it's a fairly significant one. And so anyway, I have this resource. Message me. I'll send it right to you. It's been really helpful for a lot of people.
No, I love that. And then with that being said too, I know a lot of people are like, well, I'm hurting, so I don't know like how much exercise is appropriate or what I should do. I actually have a resource it's a free resource on my website too. It's called the traffic light system and ladder system when training with pain. Basically, if you think of a traffic light with red, yellow, and green lights, it kind of breaks down what you should be looking for in order to be in each one of those. Whereas the green means you're good to go to sort of increase your intensity. Yellow, you might want to pull back a little bit or sort of stay where you're at. And then red, obviously, hey, you did too much for what your body can handle. You definitely want to pull back next session. So it can be a really helpful strategy in order to help people know that, hey, it's okay to move. It's okay to exercise. We want you to continue to do this stuff, but you just need to do it in a smart way to where you're not overloading what your body can currently handle, especially when you're dealing with injury.
Send me that. I'll try to put that in the
I
show
will.
notes as well. Okay.
I will.
That's great. Uh, Try to think what else. Okay. Are there any other pain management strategies? If NSAIDs are off the board, are there any other pain medications that are actually fine? Are there any other things you recommend?
So acetaminophen, Tylenol, Motrin, all of that can be beneficial. Obviously, when it comes to pain relief medications, I am very intentional about when I want clients using them because the last thing I want a client doing is taking Tylenol. Because the reason why we can suggest Tylenol is because it's not an anti-inflammatory, so it's still going to allow that inflammatory process to happen. It's just simply reducing that pain response. But I do not want clients taking pain medication before they go and do a rehab session or before they go into the gym after injury, because now we're just blunting that pain response that your body is using for a reason to communicate with you. And so you're severing that line of communication, and it's so much easier to push past that actual tissue tolerance when you're not able to feel what your body is trying to say to you. So a lot of times, instead of having them, take it before a session, I'll be like, hey, hold off on pain meds. I want to see how you feel during a session. I want to see how you feel directly after a session and for the next several hours after. And if pain levels start to rise after that, that tells me, okay, that means you probably did too much during the session because we want those levels returning to baseline about like 24 hours after a session. And so that would be an appropriate time to be like, okay, if you want to take some pain medication, this would be a good time to do it.
Okay. It's funny because I had a client recently come in. She had an incident where a dog crashed into her leg, which she's had a history of stuff with, of knee, like serious knee problems. And we've been, getting her really strong, and this dog took out her knee. So she's waiting for word on the nature of this injury, but it may be an MCL or PCL issue. Now, she still showed up for her workout. She's able to walk around a bit on it, but she actually did take a pain medication before coming in. So I thought about this, and her logic was it was her to be able to get there. So is there any allowance for someone who it's the difference between being able to go do all the positives versus not situational?
Yeah, it's definitely going to be situational. Taking pain medication in order to like go out and get groceries or go to work for the day and get through the workday, that's one thing. But when we're actually doing like loading of tissues, unless we are totally not loading that side at all right now because
And we
you are in,
didn't. And we
yeah, okay.
didn't. Yeah. Yeah.
In that case, then, if you're not loading it at all, then I'd be like, yeah, sure, totally fine to take pain meds in order to make the rest of the session more comfortable. But if we are going to be loading that injured or painful extremity, I definitely don't want pain medication in my clients' systems.
Brilliant delineation. I'm glad I asked because I wouldn't want anybody to think, oh, I can't take this at all for anything, specifically for loading. Okay, I think that's a wonderful rule of thumb. Great. Let's see what
Yes.
else I got for you. So, ah, why isn't surgery the likely solution for rotator cuff injuries? And we can even broaden that out for a lot of injuries because I think there's a lot of people who there's an injury and they immediately think, okay, I need an MRI and I'm going to need surgery and this will fix this shit. But now it seems less and less like the correct, way to solve these problems.
Right, right. And so a lot of these surgical procedures were, one, invented by surgeons, duh, and used to be thought of like the gold standard of fixing an issue, whether it is a torn muscle, whether it is a torn, just soft tissue when it comes to like rotator cuff tears, meniscus tears, even into the lower back when we have disc herniations and disc bulges and all that stuff. It used to be thought that, okay, you have this going on, you injured yourself, you need to go see your primary care, you need to go get an MRI, and then you need to be referred out to an orthopedic specialist or a neurosurgeon in order to wait for further approval of what's going to be next. Well, when you do all of that, the amount of money that's already being spent upfront, even with good insurance, is already pretty darn high. And now we are getting images of people's shoulders, lower backs, knees, where they could have had these tears or these disc bulges in their body happening for quite some time. And now it just became symptomatic, maybe because you, I don't know, went outside and still wanted to plant new plants in your front yard for spring and you used a shovel for the first time since last year. So when it comes to all of this stuff, we have pretty much a research study kind of supporting almost every single type of surgery where they compare the actual surgery performed. So if we're talking about rotator cuff and you actually have a rotator cuff tear and going in and performing a surgery to fix the rotator cuff tear. Well, then there's another study group that go in and get a sham surgery, meaning that an incision is, they're knocked out, an incision is made, and then it's just sewn back up. So no surgery was actually taking place, like no tissues were actually repaired. And then afterwards, these groups are compared, and we know that we are seeing very, very similar outcomes and positive outcomes when it comes to not only pain levels, but their functional mobility to reach their arm overhead and do all of their daily tasks. So we see this for, like I said, meniscus. We see this for rotator cuff tears. We also see this for lower back, disc bulges and protrusions. And so we also, for all of these different body areas, have studies that take groups of people with no pain at all. So no shoulder pain, no back pain, no knee pain, no nothing whatsoever. And just put them and get an MRI image just to see what we can find. And there are pretty drastic findings on almost every single group. And then as someone gets older, the percentage and the incidence of finding this stuff becomes even higher. So we know that not only are these tears and soft tissue changes taking place and happening in people with zero pain, but when we compare surgery to non-surgical, the outcomes are about the same, if not a little bit better for the conservative option, because now we are not going into all the risks that are accompanied with a surgical procedure like infection, delayed healing times, and all that stuff.
So immediately makes me think of two things. I'll start with the second. So it's a quote from muscle doc Jordan Shallow, and he says that the human body is good at outfunctioning our structure, and in reference to structural injury, there's so much there's redundancy, rotator cuff especially, and the muscles that connect through intersect through the shoulder, manipulate the shoulder blade. There's just so much there that if something is structurally, you know, compromised a little bit, there are many other things that could actually help out. And my guess is just you don't manifest as pain or movement dysfunction. And
Mhm.
to further your point, I mean, and it's my understanding that there is not a great relationship between these things that appear on MRIs and people's experience of pain or, movement issues, right? And then the
No.
second thing you made me think of was you just explained faith healing, like how that shit works, right? I mean, we know that's literally con artistry, but at the same time, placebo and the expectation effect are powerful stuff. Now, I wouldn't recommend people go get faith healing for things like cancer and those type of diseases. I wouldn't recommend it anyway. But you start to understand how people literally experience less pain when they go into shit like this.
100%. And I'm not saying getting MRIs are bad. I'm not saying getting surgery is bad, but you really, really need to give conservative treatment and the rehab process time to work its magic. Because the issue that we run into is, once you get your MRI and you go see the orthopedic, they're like, okay, you need to go to 6 to 8 weeks of PT so that your insurance will approve surgery. Well, guess what? 6 to 8 weeks of PT is not enough in order for you to get back to your previous function. It's probably just enough to scratch the surface. And it blows my mind that people will go the surgical route and have a recovery time of 3, 6 months, all the way up to a year for a surgery, but they won't dedicate 3, 6 months up to a year for actual conservative treatment. And that is unfortunately just the society that we live in. One, how our medical system is set up in when it comes to injuries like this. And then two, how everyone wants that quick fix. They think that something is torn or something structurally wrong, and they want that quick fix in order to sew it back together so it's not torn anymore. Well, I always like to say that rehab and tissue healing is not Amazon Prime 2-day shipping. This shit takes time, and you need to be bought into the process in order for this stuff to work.
Oh, that's fantastic. And obviously, there are going to be situations. Anybody who follows sports, we hear about athletes all the time having surgery. So I have a theory that we probably see this overrepresented in that
Yep.
space, right? And I mean, they probably have faster access to imaging, probably better quality. They probably have some of the top people. You think in baseball, if anybody's familiar with this, we often have UCL tears, which requires Tommy John surgery. Now, that is a thing that actually can allow someone to continue on with the career. But these are also high-level athletes. Our friend Bailey, she tore an ACL and she did have reconstructive surgery on her ACL. She also has undergone extensive rehabilitation stuff and strengthening, and she's very adherent, so she's recovered really well. But that's a one of those situations where we probably need surgery. If someone full thickness tear of a bicep or pectoral tendon, those are probably important and fairly imminent surgeries that we seem to have, or a full thickness rupture of an Achilles tendon. But even then, we are now seeing, I think this is fairly recent, that people have had, I think, Achilles and ACLs. I don't think this is the maybe this right, maybe like spontaneously heal. Can you explain that better? Like what's going on there?
I don't know if I've heard or read enough on Achilles, but I definitely have heard and read about ACL. So
Mhm.
basically, when you have an ACL tear, your options are to get surgery or to try and manage and see if your body can heal things on its own without surgery. And there are actually some really, really good success rates with your ACL pretty much sort of healing itself after a tear, which is wild. But I will say, I want to say with some of the studies that I read, they didn't have the best research study design.
Mhm.
So I still want more information on how this
Mhm.
is sort of coming out and how this is affecting people's outcomes, not only like soon after the tear is happening, but 6 months to a year to 5 years to 10 years, kind of like the same kind of studies that we have when it comes to rotator cuff tears and that aspect of things. Because yes, you obviously want to think about things in the short term, but I also want to know the effects that are happening long term when it comes to either getting a surgery or not getting a surgery.
And I suspect that in my inclusion of Achilles there may not actually be accurate. So I would just like throw that away because I definitely know the ACL is where this stuff has been most talked about. And again, this is in full ruptures, right? Because if it's a partial tear, then over time rehabilitation, we can see those grow back because it's still attached.
And I do want to touch back on,
Yeah.
seeing athletes get these injuries and get surgeries. Guess what they're doing nonstop all day long after they have these surgeries? They are in the rehab process and they're working every single day in order to get back to where they were prior. And that's why we're seeing such faster recoveries and more success rates when it comes to surgical procedures and professional athletes versus Gen Pop. Most of the people that get these surgeries aren't really bought into the rehab process anyways. They're kind of like, hey, I got this shit fixed under the knife and I'm gonna be good to go and I'll go to PT for a few weeks and then I should be able to manage on my own. I saw this time and time again when I worked and treated in the clinic for 3 years. And so I think like that stark difference between those two populations is why we are seeing such a difference.
And there's also something that almost no one's talking about is most of these high level athletes have access to uh, cutting edge peptide,
Mm.
protocols, which there's not a great understanding in the mainstream about that stuff. I certainly don't have a great understanding of it. They're probably using things like I think it's hyperbaric chambers, like certain things that also can accelerate and I don't know mechanistically how that works, so it's probably not worth getting into the weeds on that. But we know that they have greater access. And there's also a fair bit of stuff that's definitely in the gray area and even crossing over lines. I mean, we lots of instances where pro athletes have been, quote, busted for using HGH, human growth hormone, which has powerful healing effects. And then, of course, that is often banned in these organizations that if they test positive for it, they can get suspensions. But in the case of someone's career and millions of dollars, that's why these athletes sort of take those risks, I suppose. So complex stuff to say the least. But to your point, I think you alluded to, it's not a wise to look at what athletes are doing on these surgeries and the timelines and consider this to be representative of what everybody else is going to experience.
Correct. And, with that being said, too, it's not like I'm anti-surgery. I'm not. I am anti-early unnecessary surgery. So, give this some time unless you have, a traumatic car accident or a traumatic dirt bike accident or traumatic accident in the weight room where we need to have surgery like now and soon. I would love if you could give yourself some time to see if some of this conservative management stuff can help by finding a good rehab professional that also knows strength and conditioning and loading and all
Mm.
that. not all rehab professionals are made the same, and like me and like all the other PTs that you've had on the pod. Um, Give this
Yep.
stuff some time, and then if you're still having issues, that is when the talk and consideration of surgery should be coming up. It shouldn't necessarily be coming up straight at the beginning.
I will comfortably say I actively avoid allied healthcare professionals like physios and chiros who do not understand or value resistance training. Sorry.
Yes,
Like,
please
yep.
also avoid it. Coming from a physical therapist herself, it's not that I shit on the profession. There's just a smaller portion of us who actually know how to use the updated approaches to rehab that actually work. And those updated approaches do not include hot packs, ice packs, therapeutic ultrasound, kinesiotaping, and having you lie on a table and do super low level exercises for the whole entire 8 weeks that you're in PT.
That's why I brought you on. That's why I recently had Adam Meekins. Anybody who's listened to this, number one is you got to go listen to the Adam Meekins episode. He is absolutely wild. Dr. Sam Spinelli again, and then there's some other people. Alex Sterner is a strength coach. He's not a physical
Yes.
therapist. Dean Somerset, again, same thing, not a physical therapist. But I honestly think Dean is probably knows more about rehab than most physical therapists running around. So there's a lot of episodes that are like directly on these topics or adjacent if you're really interested in this. You were about to say.
Yeah, I don't know. Oh, I
Oh,
was gonna say, oh, Alec, he just tore his adductor.
you know what? I saw three different people within a week tear
And
their
then Jason
adductors.
Brown.
I was about to say Jason Brown, so he's coming on
Huh?
the podcast pretty soon. He just tore an adductor, and I'm struggling to remember who the third person was. But I was like, seems like everybody's ripping adductors. I think it
What
might
is
have been.
this? Wait,
I think. I don't know. I think it might have been Angus Bradley, but I might be like completely imagining that out of thin air. Probably wasn't, but I know. So, yeah, Alex did. Either way, that's just like rough stuff. So I'm going to probably learn a lot more about adductor tears in the near future as these guys post about it. So uh,
document
everybody
the.
can get you on Instagram at dr.susie.squats. What other resources have you got?
If you go onto my website, I have a ton of freebies that you can download. I have a free 4 week strength training program, tight posterior pelvic floor, the traffic light system with training with pain, how to use RPE and intensity-based training for more gains, less pains. I also have an online group strength training program where you get to choose between 5 different programs. Where you can lift anywhere from 3 days a week, all the way up to 6, depending on you and your goals. And then my team and I also offer completely personalized, remote, online rehab and fitness coaching. If you're currently struggling with an injury and your in-person rehab is not cutting it, we would love to help you. And we have massive success with all of our clients that we work with online.
Love it. This is why I brought you on. I want everybody to go follow you, and I'll keep shouting this out. I would love to continue to grow this podcast, share the people I'm having on. And one of the reasons why I put the podcast on hiatus, if you go back, because before, for anybody who's newer, a lot over 300 episodes are really geared towards fitness career development. And I think for coaches, there's a just gold mine. I've had the industry's who's who. You haven't, a previous episode more along those lines. And I think there are very good evidence-based human performance, health, lifestyle podcasts out there. But we also consistently see these clips of, there's one recently, I won't get into specifics, but they're all the time. This stuff is stitched on social media where you get people, and sometimes they have educational credentials and sometimes they don't. And they say these sensational things that are not supported by the evidence. And sometimes these podcasts get into really woo-ish territory. And I'm genuinely trying to create something that is on average better. I know across the board we will not bat 1000% everywhere for every guest, but the goal is to elevate this. So if you are frustrated about what's out there already, please share this with more people. It helps me get great people like Susie in front of more people. And then that way they have access to your media. So guys, thank you for supporting. And recently, it's been really cool. I've actually been gaining multiple sponsors, and that just all started happening really fast. So, just please support my sponsors, Renaissance Periodization, and for local people, Just Bite Me Meals right now. And I will have a third amazing one to announce in the very near future. So, thank you guys for all that. I do not have those people coming knocking on my door without your listening and support. So, thank you. Thank you, Susie.
Of course, thanks for having me.